Good afternoon, everyone. Thank you for joining us today for Survivorship Care Plans, Introducing a Novel Technology to Transform Burden into Opportunity. My name is Shira Morales, and I'm the Project Manager for Healthcare Professional Education at the GW Cancer Institute. Before we get started, I would like to take a few minutes to go over some housekeeping remarks. We ask everyone to keep their phones on mute to avoid any background noise and disruption during the program. Also, please note that today's program is being recorded. We will use the question and answer feature for this webinar. You will see a question and answer box at the bottom right of your screen. If you have any questions at any time during the presentation, please type it in and we will address it during the Q&A portion at the end of the webinar. The questions are anonymous, and I will repeat the question. We will take questions again at the end of the presentation, but feel free to write the questions in the Q&A box as we go, and we will make sure to answer them during the time allotted. We will also like to use the chat box feature, which is on the top right side of your screen. You can use the chat box feature to interact with each other. Because we will be talking during the presentation, we probably will not be able to keep up with the chat. So just make sure that if you want to ask any questions, use the Q&A box on the bottom right corner. And as a note, again, before we get started, a PDF of the slides is available for download during the Q&A section of the webinar, as well as now in the beginning. And we will be sending out a PDF of the slides and a link to the archived webinar to all of the webinar participants. The recording of the webinar will also be archived on our website along with any of our previous webinars. You can live tweet us throughout the webinar at GWCancerInst, INST, and use the hashtag CASNPwebinar. I'd like to take a moment to review today's agenda. I will provide a brief overview of the Center for the Advancement of Cancer Survivorship, Navigation, and Policy. Dr. Carrie Tompkins Stricker will provide a presentation on survivorship care plans, introducing a novel technology to transform burden into opportunity, a live demo. And we will continue the webinar with participants' Q&A, and we will do so again through that Q&A feature at the bottom right of your screen. For full disclosure, please note that the GW Medical Faculty Associates does use On Q Health for survivorship care planning. I want to provide you with a brief overview of the Center for the Advancement of Cancer Survivorship, Navigation, and Policy, which brings you today's webinar. The Center for the Advancement of Cancer Survivorship, Navigation, and Policy, which we affectionately call CA-SNAP, was created in 2009 through a generous grant from the Pfizer Global Health Partnerships Program. The mission of the center is to advance cancer survivorship and patient navigation efforts locally and nationally through education and training, policy analysis, outreach, and research. The center offers survivorship and navigation resources that are available online at our website and through a monthly e-newsletter. Additional materials is sent through our CA-SNAP mailing list to over 2,400 subscribers. We write white papers, create case studies, and work cooperatively with other healthcare organizations to advance patient-centered care. We also share summaries of meetings and roundtables we have hosted to catalyze patient navigation, cancer survivorship, and patient-centered care initiatives. Through CA-SNAP, we have offered several trainings. We were recently awarded funding from the Centers for Disease Control and Prevention that will help us translate our existing in-person trainings to online format to make them available at no charge to participants. We recently launched our executive training on navigation and survivorship, which is the nuts and bolts training for building and sustaining navigation and survivorship programs. We are also finalizing our competency-based oncology patient navigator training that will be available through the online academy in the upcoming weeks. In collaboration with the American Cancer Society and the Centers for Disease Control and Prevention, the GW Cancer Institute also hosts a free online educational program for general medicine physicians, physician assistants, nurse practitioners, and nurses who practice in a variety of primary care settings. The Cancer Survivorship e-learning series for primary care providers is designed to increase PCP's awareness of the ongoing needs for cancer survivors, increase their knowledge on how to care for cancer survivors, and increase their ability to provide follow-up care for cancer survivors. Free continuing education credits for all of these educational opportunities are offered at no cost. If there are any topics that you would like to know more about, please let us know. Our email address is listed on the screen as casnp@gwu.edu. Today we are pleased to introduce our presenter, Dr. Carrie Tompkins Stricker. She's a nurse scientist and oncology nurse practitioner with 20 years of experience in the delivery, development, and evaluation of quality patient-centered, supportive, and survivorship care for individuals with cancer. She received both her PhD and MSN degrees from the University of Pennsylvania School of Nursing and her BSN from The Ohio State University. She is internationally recognized as an expert in supportive and survivorship care for cancer survivors. Thank you so much for joining us today, Dr. Stricker.
Thank you so very much. I am so thrilled to be here today and to have this opportunity to share with today's webinar session and participants more about the work in survivorship care planning in general, as well as specifically about On Q Health and how we have developed a solution to help centers meet and exceed this standard and recognize the real value and opportunity of survivorship care. I'm very, very grateful to the Center for the Advancement of Cancer Survivorship Navigation and Policy for this opportunity, and to our colleagues at GW Cancer Institute and medical faculty associates for their willingness to let us use their environment to show today's demo. I see a lot of familiar names joining today's webinar. Welcome, and thank you to all of you who are attending, and including those among you who we've already met and new individuals. I think at this point we are going to start out with some poll questions. So you should be able to click on your screen here. You'll see 7 questions that we wanted to ask today to get a better sense of survivorship care and care plan delivery across our webinar participant audience. We're asking about the workflow and resources of survivorship care planning, how far your center is with implementing these care plans, how you're, which disease types you're currently providing to, or actually particularly here, what you're most concerned about, which disease types out of which the COC emphasizes the need to deliver these care plans, which are you most concerned about meeting that need and that mandate. That's question 3. And I think you all can read very well, so I won't read all the rest, but this will help guide my presentation approach today to understand how our webinar audience is interacting with and delivering survivorship care plans at your institution. So we'll give you a little bit more time to do that. Or interested in the certifications that your institutions are seeking, Commission on Cancer, National Association of Programs for Breast Cancer, ASCO's Quality Oncology Practice Initiative, that is COPI, and how you're currently getting data into your treatment summary templates, and your perceptions of the survivorship care plans that you're using. The more responses we get, the more helpful it will be in understanding what are the real challenges to survivorship care plan delivery and how we can help overcome them here at On Q Health, as well as GWU's Center for the Advancement of Survivorship and Navigation. So thank you for your interaction here. I see a lot of activity. Monique, I'll let you make the call as to when you think we should close this down.
Okay, I think we're ready to move forward.
Excellent. So I'm going to share my screen. One comment I will make right out of the gate is that I see there are a significant proportion of folks on this call who are still relatively early on in the process of delivering survivorship care plans. They're just getting started or delivering to less than 25% and have some concerns about meeting the standards. So makes sense why we're all here today. Okay, so I am going to start by giving you a brief overview of On Q Health. So who is On Q Health, and why are we here talking to you today? As I mentioned initially, we really want to help the audience today see survivorship care plans and survivorship care delivery as a fantastic opportunity to improve the quality and patient-centeredness of care, and not just a burden to overcome or a box to check to meet a mandate. So at On Q Health, we are a clinician-led information technology company, and the clinician leadership is a factor that differentiates us from other software and content solutions in this industry. So as you heard in my introduction, I led the clinical programs at University of Pennsylvania's Abramson Cancer Center for 7 years prior to founding On Q Health. And in that process, I also led a 13-center pilot trial, multi-site pilot trial, looking at the feasibility and outcomes of delivering survivorship care plans, and really sought from those experiences to create a solution with my partners that would make this process easier and more effective. So at On Q Health, we provide personalized care plans, not just survivorship, but across the whole cancer care continuum. And we do this so that we can improve the clinician-patient relationship, engage patients, improve care coordination, help centers meet quality standards, and ultimately mitigate the risk of healthcare costs, including hospitalizations. How do we do it? Well, we gather patient-reported and clinical data to generate personalized care plans at the point of care efficiently and effectively to improve overall individual patient and population health. The co-founders of On Q Health, beyond myself, are Madeline Trupkin-Hersfeld, who is a nurse also by background with a business degree from Penn's Wharton School, and who is the founder of IMER, a continuing medical education company that provided well-recognized oncology continuing medical and nursing education to providers around the country, and thus managed a content business very effectively for over 12 years. We joined forces and brought on board Bob Bowsmith as our Chief Technology Architecture. What's important for you to know is that he has expertise in systems integration and systems architecture, which are critical for any health IT company, especially with interfaces with the EMR. So what is our platform? What is the On Q Care Planning System, and how does it work? So with respect to survivorship, this first step is an optional step, but one many of our centers take advantage of to really further personalize that care plan to the patient's needs and concerns at that visit. If a center chooses to use this step, they'll provide a patient with a tablet, or the patient can do it on any other mobile or desktop device, fill out a highly personalized disease and treatment-specific questionnaire on that mobile device prior to their office visit, whether that be from home or in the waiting room. Then what we do is we pull diagnosis and treatment data from either the EHR or cancer registries, or for centers who don't want to take advantage of or work on those interfaces, they can enter those data manually. But one of our solutions that really makes a difference for our customers that you'll hear about later are our interface solutions. We take those data, patient-reported if applicable, and clinical data to draft a personalized care plan by processing it against our complex rules engine and clinical algorithms that our faculty around the country, 200 plus strong, have helped us to develop and maintain continuously. And then that draft care plan can be finalized at the point of care and delivered immediately to the patient, with the care team counseling them on those recommendations. I mentioned we have a diverse network of faculty. These are physicians, nurses, rehab experts, nutritionists, psychologists, physical therapists, and more, who all help us to develop our care plan content and make sure we're scanning the literature, scanning meeting notes, keeping up to date with the guidelines so that you have continuously updated care content. And we partner with leading professional societies both within and outside of oncology, of course, ASCO, ONS, NCCN, and MASC, But to provide personalized management of late effects and symptoms like hot flashes and others, we need to go outside the oncology space as well and partner with organizations like the North American Pain Society, or Menopause Society, and the American Pain Society. And our approach to our patient educational materials is we take advantage of the rich content that exists from our advocacy group partners. And our faculty help us to choose the best education and resources available today and embed that into our care plans at the point of care. So you're going to see a live demo of this, but just a quick screenshot of how all this translates into practice or into the platform and the care plan itself. Is what you'll see is that our care plans are personalized automatically for the individual patient. So you're seeing here that this patient, because of a history of a BRCA mutation, is told that she needs to get an MRI in addition to her annual mammogram. Normally, this is something you'd have to manually populate in your template that your institution has developed or that may be within an EMR. And the patient is told about what other recommendations she needs to complete because of that BRCA mutation, including having her ovaries removed. Again, late effects are highly personalized. A patient who didn't have lymphadenectomy for pelvic surgery, during pelvic surgery, would not get education around lymphedema prevention, but this patient did. So she gets that information and is told concrete, specific advice about what she needs to report into whom. That is all data that came out of much of the literature to date on individualizing care plans at the point of care, what are patients and providers' needs, and how do we make them more effective. Now, all of this, as you are all keenly aware on this call, has translated into some mandates and standards that many of you are struggling to meet. So in September of 2014, in recognition of the fact that centers were struggling to meet this standard, the COC clarified their standard for survivorship care plan implementation so that by January of 2016, a short 8 months away, centers will have to be providing 25% of their patients with care plans, but 100% by 2019. And very importantly to those of you on the call, 60% of whom said they're most concerned about breast cancer, fulfilling those mandates. If you are seeking or have NAPBC accreditation from the National Accreditation Program for Breast Centers, by end of this calendar year, 50% of your patients must have received a survivorship care plan. Now, one thing COC and ASCO recognized is that a lot of effort had been centers were putting into just abstracting and entering treatment data, so they made some updates to this standard. And ASCO, you all should read this paper if you haven't yet. I will summarize the key points in my lecture, but led by Deb Mayer and colleagues, in October last year, ASCO updated their clinical expert statement that outline the required care plan components. An important point from this is there is still very much there's a very clear treatment summary needed, but some of the granular detail like TNM stage, radiation dose, these things were made now optional rather than required, with the real driving emphasis on what data needed to be included in the treatment summary being what is going to drive follow-up care, recognizing that the electronic medical record really will always remain the main source of detailed information like radiation dose and will need to be referred to for that purpose. With that change in focus, that allowed a greater emphasis on the personalized follow-up care plan. So what ASCO now emphasizes in their expert statement, which COC recognizes as the standard for meeting survivorship care planning, is that the follow-up care plan needs to be highly descriptive of what needs to be done and by whom, so assignment of responsibility, is it primary care versus oncology care, and that it needs to be personalized to that patient at the point of care, having their oncology team member contacts, what their ongoing adjuvant therapy needs to be, what are their ongoing problems, and how can those be best managed, What should their individual surveillance for cancer and non-cancer look like for that individual? What symptoms do they need to report? And given their disease and their treatment exposures, which late and long-term effects are they at risk for? And how can they proactively prevent or manage these? There's an emphasis on the need to identify emotional and practical concerns and educate the patient on a health behavior and promotion plan, which they recommend individualizing and tailoring to the patient where pertinent. So obviously this creates some challenges while extending some of the previously existing challenges. So we still have the challenge of populating the treatment summary, which ASCO has improved with the reduction in granularity of data elements, but it is still a challenge to gain that information. It lives in many different places. Keeping the content evidence-based and up-to-date is resource-intense, and many institutions are pulling together disease-specific committees to create these templates and algorithms, and then have the challenge of maintaining that content and keeping it up-to-date continuously across all disease types. And then the additional challenge, which in my study across the Livestrong Centers of Excellence, 13 academic and community centers said they spent between 60 and 90 minutes delivering that care plan at the point of care, largely because of the work of manually populating the care plan and tailoring it to the patient at the point of care. And clearly those aren't sustainable processes, but they're really critical to our survivors in terms of their care and their outcomes. The breast cancer survivors in our multi-center study said that the 20-page care plans that they received in our study 4 years ago were overwhelming to them because they had so much content and they weren't sure what was applicable to them. Many of our participants in our own webinar here at On Q Health, which we did about a month ago with Deb Mayer, Alicia Rosales, and Jennifer Klemp, our participants on that webinar said they were very concerned about their ability to keep their care plans up to date. And in fact, so 70%, almost 70% said that, or almost 60% said that their care plans were not updated at least annually or they weren't sure. And then to the point of personalizing to the patient's symptoms and concerns, this is where 65% of our participants said, we don't do that. We don't do that yet. We don't have a mechanism for that, yet it is something that ASCO requires in its new expert statement. So now I want to talk a little bit about On Q Health and how we can turn these challenges into opportunities. We address directly the issue of data for the treatment summary in two important ways. So I mentioned earlier that cancer treatment and diagnosis data lives in many places. Patients are often seen at many institutions. Well, the place that has to pull all that information together is the cancer registry at each certified cancer center. And so we will be demonstrating with our first pilot center, and we have several others closely to follow, next month, our cancer registry interface that pulls across tumor registry data directly into our platform. We intend to have this as a product late summer, and our intent is to deploy hundreds of these implementations over the next year. With our EMR integration, we validated our approach with Epic and Cerner Corporate, and we seek pilot centers to demonstrate that validated approach with us, and there will be incentives to centers who wish to work with us on a pilot. So we encourage you to contact us if you are interested in being one of those centers, either for Epic or Cerner or for other EMRs. The other challenge that we turn into an opportunity is the content that we provide. I've already spoken quite at length about how we make this evidence-based and continually updated and disease-specific, so that we have templates across all of the major diseases covering 70% of cancer survivors by end of 2015, and then the rarer cancers soon to follow. And because our care plan content is so rich and personalized to the patient, this can help centers to maximize reimbursement opportunities. Our EMR interfaces are intended to bring that data across so that it can provide documentation of the complexity and the coordination of care of the visit and enable centers to maximize their reimbursement opportunities through visit billing codes and new performance-based payment models proliferating now, like the oncology care model, which requires the delivery of individualized treatment plans at the beginning of treatment, which we also provide, and survivorship care plans. So just a little bit more detail on that. You can access higher level building codes by the complexity of the visit. We save time through bringing across disease and treatment data and personalizing the care plan at the point of care. And we reduce hidden costs by maintaining the content across diseases up to date so that teams of clinicians and IT don't have to build and then continuously maintain at your institution. We also provide value through our data analytics and reporting platform. So all the data that comes into and goes out of our platform into our care plans is data that can be reported upon. And you can see here in one pilot study at Moffitt Cancer Center in Tampa, in the first 67 breast cancer survivors there, we found a mean of over 5 referrals per patient for the following types of symptoms. No surprise, anxiety and depression were top among them, fatigue, sleep, weight. So these were referrals to services at the center like physical therapy, psychosocial services, nutrition, genetic counseling, rehab medicine, and lymphedema management that are all secondary revenue opportunities. And you can use our reporting and analytics then not only to document that downstream revenue, but also use those data for quality improvement. And navigators can use these reports for care plan follow-through, as can programs. So the genetic counseling program at Billings, for example, runs reports to see who was referred to their genetics program and track whether they followed through to ensure that they're not lost to follow-up. So with that, hopefully you're eager to see our demo, and that is what I would love to do next. So I'm going to navigate to that environment. I would just like, maybe Monique, you can verbalize for me that you'll see that screen as soon as I log back into it. Okay, not sure what just happened there, but we'll make a quick recovery. So Monique, can you see the GWU screen? Huh?
No, we cannot see the screen. Are you able to see that share my screen button that you could click on?
Yeah, 1 second. It looks like it just decided to get a little tricky and log me out of the session from a screen sharing perspective. Not sure what I did there. So I am going to log back into it. You can hear me though, right?
Yes, we can hear you.
Okay, bear with me. Not sure why it did that. Maybe when I escaped out of my Prezi presentation, which, by the way, while you are waiting for me to rejoin, that is available to all at the link in the panel below. So the PDF of today's presentation you just saw are available in the panel below. Okay, I'm logging back in here, Monique.
Okay.
Reconnecting. Okay, I'm going to hang up here.
We want to thank all the participants for bearing with us while we accommodate.
And Carrie, we've got a bit of an echo with your phone.
Yeah, I hear that. I'm resolving that. So we just need about 30 seconds. Is there a way while we're waiting for me to reboot so we can get rid of this echo that you could bring is there the ability to bring the poll results back up, or?
I sure can.
Because I think this is really interesting information for the audience to see. And we're doing great on time. It's just 12:30 now. I just can't see it. So maybe, Monique, if you could talk to that for me, would you mind so doing?
Okay, let's take a look here. Was there one particular that you were interested in seeing what the results were?
I think I already addressed number 1 through 3. It'd be interesting to see how folks responded to 4, 5, and 6. I should be back with you just momentarily on the screen sharing.
Awesome. So with number 4, where you asked what certifications does your center currently have or is actively seeking, most of the respondents, with about 70%, responded with COC, 31 responded with NAPBC, 11% responded with the QOPI, and you had about 11 respondents that it was not applicable to, and then you had 5 respondents that actually indicated that all of the above were actually activity seeking. Are you able to see that now? Okay, it appears that Dr. Stricker is having some technical issues here, so we apologize and we thank you for sticking with us. We're going to wait for her to come right back online. A few minutes here.
Okay, I am back. I'm hoping we don't have echo, though.
Nope, you sound great.
Perfect. Okay, so I heard you present the information on the standards and certifications. So now at this point, can you reshare the screen with me?
Yes, ma'am.
All right, thanks for going through that. And here we go. So now I'm just going to navigate back to where we were. And as I mentioned earlier, I'm very grateful to the folks at GWU's Medical Faculty Associate Survivorship Center for enabling us to do the demo in their environment today, particularly Carrie Tilley, the Survivorship Care Clinic coordinator. Okay, so I'm sharing, right? You can see the George Washington University Medical Faculty Associate.
Yes, we can.
Okay, I'm concerned about the echo. Is there an echo still?
Now it stopped.
Okay, good. Thank you. All right, let me dive right in. So this is the GWU's environment. I am going to log in and show you a patient. I created a demo patient for today. This is going to be a young woman. And you're still hearing me fine, correct?
That is correct. You're loud and clear.
Excellent. So this is going to be a young survivor, a breast cancer survivor of 41 years of age. You will see here in the top left corner that we would bring across on our EMR and registry interface, MRN, and sociodemographic information. And you would see also that we would bring that across from the registry into a survey format so that the provider reviewing the survivorship, the treatment data for the survivorship care plan could validate that this is indeed correct and make any changes necessary. So this woman was diagnosed in April of 2014 with a right breast cancer, a stage 2 node negative, hormone receptor positive, HER2 negative breast cancer. She had a mastectomy, and I'll tell you more about why in a moment, in May of 2014, nodal surgery, and then went on to receive 4 cycles of dose-dense AC followed by weekly paclitaxel ending in November 2014. She did not receive radiation, but then started hormonal therapy with exemestane and Lupron as per the SOFT trial in December 2014. This patient did undergo genetic testing for the BRCA1 or 2 genes and was negative. So she was young, so underwent that. Now, the reason that she received this test, or that she likely developed breast cancer at such a young age, is because she had Hodgkin's disease and received mantle radiotherapy to the chest prior to age 30. In fact, she was in her 20s in 1995. Of course, as you know, the treatment summary and care plan also have to include the patient's care team members. And so what our solution does is provide pre-populated lists from which the team can select for that individual patient. We also pull across gynecologic history and height and weight from the EMR. I'm going to submit that survey. What you will see, what I'm going to do next is show you a patient-facing symptom survey. So if you wish to include that in your workflow to make the care plan better tailored to the patient's current symptoms, you could. Let me open that up for you. The patient would fill this out at GWU, for example, in the Medical Faculty Associates Survivorship Clinic. They're filling this out on a tablet in the waiting room. We use validated symptom questionnaires that are specific to the patient diagnosis and treatment. So this breast cancer patient who is post-therapy in the survivorship setting will get a common core of questions, fatigue, depression, and anxiety, and pain, that all cancer patients will be asked. But you will notice here she's asked about neuropathy symptoms, and she's asked about joint and muscle pain because she is on an aromatase inhibitor. She rates this as a 5. She has some vaginal dryness, and otherwise these are her main concerns. And at each visit, we ask patients to report on their top concerns for the visit. This new survivor, only several months post-completion of chemo, newly on hormonal therapy, is very concerned about her risk of recurrence, what she can do about it, and what she needs to report to whom and when. We also ask about ER visits and hospitalizations. So then the patient turns their tablet in, and now what I'm going to show you is if you are the clinical care provider for this patient, what's your workflow going to be? Well, let me pull our young woman back up. You'll see in here that her diagnosis and treatment data is validated. Her symptom survey has been submitted. You, as the provider, can look at the bottom of the screen and see here exactly what her top concerns are. That was work that grew out of our research at Penn. What you can do from this point then is go right to creating the survivorship care plan. It'll show you the treatment summary and the personalized care plan. So let's do that. The care team information is summarized neatly at the top along with the diagnosis and treatment summary information in a format that explains what AC is, for example, so that we're not using onco-speak. It also summarizes her genetic testing and gyne history as relevant to that patient. So she did go into premature menopause with her Lupron therapy. Her care plan for breast cancer surveillance is going to be individualized not only to her, but to the preferences of her institution. So we operationalize NCCN and ASCO breast cancer surveillance guidelines, as you see here. But you also will see that each center can personalize the way that's displayed. So what ASCO requires is that patients be told to report any new or unusual symptoms. Carrie Tilley's team has decided they want to explicitly state which symptoms the patient should call to report. And here you see, given this patient had chest radiation prior to age 30, she needs to have an annual breast MRI, and that's automatically populated for her. You don't have to manually type that in. Same with bone health surveillance. Normally a 41-year-old would not need to be getting DEXA scans, but of course she does. She's on Lupron and exemestane. And so that is automatically populated for her with very prescriptive advice about calcium and vitamin D, and localized resources. So GWU has a local health and wellness program that they refer survivors to help with bone health, fatigue, and other symptoms. And if patients wish to read more on any topic, they can navigate to the hyperlinks. This patient received adriamycin, so she's educated about her risk of heart problems, and consistent with the ASCO requirement that responsibility be assigned, we're saying here they should follow up with their primary care provider for heart disease risk factor screening, including blood pressure, cholesterol, and blood sugar. And then patients can navigate, if they wish, again, to these educational materials our faculty have directed us to include. So this was what they recommended for heart prevention, cardiovascular prevention. You can, at your own institution, import your own resources as well. Our approach with psychosocial issues is consistent with ASCO's recommendations. All patients are educated about this being a common concern and told fear of recurrence is normal. But if you need help, there's more that can be done, and here are our localized resources. So Carrie Tilley may have provided or decided for this patient that this patient's not sufficiently distressed to see a social worker or psychologist, so rejects that. But the patient is still told of the national resources they can access from a distance and reading materials about that topic if they wish to navigate. Education about premature menopause, secondary cancers, and the importance of annual cancer screenings, again with the primary care provider, giving resources to the patient if they need to establish such care. Here's a number that you can call to do that. This patient was concerned about weight gain, so we give her resources for that, exercise and reading materials. And then lymphedema is a great opportunity to showcase, again, how the advice is very brief, to the point, and prescriptive. So learn how to reduce your risk, learn more in this sheet if you wish, and go to our prevention program here locally. But if you develop any of these symptoms, you should report them to your breast provider immediately. So we'll go ahead and approve that care plan. You'll see here there was very little that the provider at the point of care did to personalize this. The system did it for them. They removed one task about seeing a psychosocial provider because the patient felt it wasn't relevant to them at that point. And then here's the finalized care plan. It's an electronic format. Most of our centers deliver this to patients via a secure email, or it can go on a flash drive. Also could be embedded in the patient portal within the EMR, and a printed copy can be immediately provided. You see it's a very similar format, only what is approved is on here. Goes right into the follow-up care plan. Hyperlinks are active, but again, we have very bulleted prescriptive advice. That's in case the patient only receives a printed copy. Bone health surveillance, all the things you saw previously. And an important point is for every survivor, we include the general recommendations around cancer screening and health maintenance and health promotion that ASCO and the COC requires. We also, of interest to some, may be that we are also building in lung cancer screening care plans this year to identify folks who should be screened with lung CTs and refer them appropriately. Healthy lifestyle recommendations here. What I do want to do at this point as well is show you, if you wish to also create an individualized active symptom management plan for that patient to address those current symptoms she reported. That can either be done separately, as GWU has chosen to do in their implementation by clicking on this Create Supportive Care button here, or it can be done as an add-on to the traditional survivorship care plan. Let me show you that supportive care plan here. You'll see again the same approach is taken. This patient is on an AI. She has moderate joint pain. She's on, this is almost certainly AI-induced arthralgia. So she's given recommendations about lifestyle behaviors. One important thing from an adherence standpoint is we know many patients stop taking or take less frequently their hormonal therapy because they are trying to minimize their side effects. So our faculty felt it to be very important to proactively educate the survivor that there are other options. Talk to us about these so we can switch up your therapy rather than you not taking hormonal therapy at all. We integrate alternative and complementary therapies into our platform, as well as individualized clinical trials. So in this case, there is one locally for duloxetine that's being investigated as a management strategy for AI arthralgias. And you can see here as well that this patient reported some anxiety, so this functions now as a distress screening tool in addition by saying, okay, we've got somebody with anxiety here. Here are localized resources that the patient can access. And again, reports of these can be generated so the psychosocial services team can follow up on people who are experiencing psychosocial distress. Symptom management, vaginal atrophy and dryness management. One thing I want to show you here is behind the scenes, you have also neatly summarized but very in-depth evidence base for managing these symptoms. Our faculty works with us. This care plan here actually was the first impetus. Patients who have vaginal dryness and who have an estrogen-sensitive tumor are not straightforward to manage. So we worked with our faculty to synthesize this evidence to explain short courses of low dose are appropriate to consider within the context of the patient's diagnosis and treatment and with a conversation with their primary provider about risks and benefits. If you're going to do that, these are the formulations in doses and schedules, and we neatly summarize the evidence about the safety of these local therapies in patients with estrogen receptor tumors and identify the references where you could go to learn even more detail if you wished. You'll see here that the genetic counseling referral was automatically rejected because this patient had previously undergone genetic testing. But as many of us know, genetic tests change all the time. So had this patient been tested 5 years ago, you could have maximized that if you wanted to refer her back for genetic testing to get maybe the BART testing, for example. But in this case, that's not necessary. She was tested just last year. And so you approve that care plan, and the patient gets a symptom management copy as well in the same format or added on to the traditional survivorship care plan format that I showed you previously. So that is what I have to show for you today. I'm going to navigate back to my slides for some conclusions here. And then we've got some nice time for questions. We've got about 10 minutes for questions. Bear with me a second. Kicked me out of this presentation, so I just have to click through to the end. Hopefully the demo has given you the opportunity to see live all of what I talked about in this presentation about our ability to overcome challenges and turn them into opportunities through our personalized assessment and care planning system and through our data analytics and reporting capabilities that allow you to track these patients, promote quality improvement, and improve overall population health at your institution, generate and report on downstream revenue. And so in closing, before questions, what I'd like to say is we have embedded a link. If you look in the doc on your Adobe Connect, you'll see a link here to request a demo. Even though you've attended this demo today, we'd love the opportunity to do a personalized demo for your care team and talk about how our solutions might work within the context of your individual center. And so if you navigate to this form to fill it out, we'll be in touch to set that up with you and any members of your care team and administration that would be relevant. And we really do hope to hear from you. So with that, Monique, do I kick it back to you for questions?
Thank you so much. So we would definitely want to respect everyone's time, but we do have several questions. So I just want to preempt you on that. The first question asks, does the updated care plan need to be created, or can an older template be used?
Okay, so I think that question is asking if we have a template at our institution, can we take advantage of that and incorporate that? And that allows me the opportunity to talk about our approach. So we have this updated care plan content that each center who onboards us is able to make decisions about how it's configured at their site. So if you have gone through that process of working with your providers to say, okay, our follow-up schedule in this population is every 3 months instead of every 6 months, you can use our care plan templates and care planning system to say just that. So you can bring content at your institution. We can match that up with yours.
Okay, thank you. The next question is, what sorts of issues do patients have who are in a rural area or may not be able to come back to a cancer center for some follow-up survivorship care?
So that's the beauty of offering a cloud-based solution, is that this is all done via the web. And actually, we are working closely on a project with 2 academic centers that would ultimately pilot that capability of providing these remotely. It's a cloud-based solution, and so that is not coming to the center would not be required.
Power of technology, right? How similar and different are the SCP standards across the different organizations, for example, ASCO or the American College of Surgeons, et cetera?
It's such a fabulous question. So there's actually pretty good alignment across the board. There are some minor differences, and if a concrete example of that, so even in something as simple as just the follow-up schedule for breast cancer surveillance, there's minor differences between ASCO and NCCN on the frequency. So how we take our approach to that is we offer both, and the center gets to choose which one better fits their practice and further individualize it to their institution if they require or desire.
Okay, thank you. This question is more, I guess, of a clarification. The person understands that the cancer registry staff is responsible for pulling the initial data over, but I think they want more clarification as to if, is it a nurse practitioner or the person responsible for creating the care plan is the one that actually verifies the history.
So that would, of course, be something that would be worked out individually at each institution, but I can tell you in our initial centers, the workflow is that the registry, as noted, does abstract that data, put it in the registry, and then they send a report, batch reports of that to our system, and it would be the institution's workflow to figure out who reviews that, but in all our centers, it is a clinician, or a clinician or a clinical navigator who does that final review at present.
Okay, and can you further clarify at what point in that process does the patient actually complete this plan? Is it after 30 days or where in the process?
Oh, so you mean after 30 days after the end of treatment?
Correct.
Is that what you mean? Yeah. So, in the COC and ASCO standards, it is outlined that having these care plans delivered proximally to end of treatment is what is suggested. There is not a specific number of days within which that needs to be done. Each center is doing that differently depending on their clinical workflow issues. And what we do with each center in terms of these batch registry extracts is we work with the center to identify the timing of when they want to do that. So do they want to do that batch move over to our engine, our cloud-based server, with those data at a defined time point, like 30 days post? No problem. Then that's fine.
Okay, we have one that's asking if On Q Health is collaborating with any of the state cancer registries.
Yes, I see that. So we have had preliminary conversations with a number of the state cancer registries. What they are they would like to reconvene a conversation after we have our first pilots in the next couple months with our local cancer registry customers and pilots, which will be well underway by this time next month. So that is on our short-term agenda. And the good news about that, though, is that all these registry data are maintained in standard codes called the NACER codes. So it is technically going to be essentially the same issue. So we anticipate no problems.
Okay. Now, just as an FYI, Dr. Stricker, we do have a lot of questions coming in. Are you available on LinkedIn, or is there any way that we can forward these questions to you in case we're not able to get through all of them today?
Of course. So I also do see, just looking at the threads going on, I've seen a number of questions around cost. Mm-hmm. So with respect to cost, and with respect to what you just said as well in terms of getting in touch with us, our website, you can navigate to that from that link here and request a demo. We encourage you to contact us directly. Our pricing structure, we believe, is very affordable within the context of the market, and our early customers, we are offering special discounts for our early customers, so we encourage you to reach out to us via our website. In terms of the list of follow-on questions, I am sure I would love to see those, and I can commit to you that just like after our own webinar, we can post a Q&A session on our website. So I would love to see those questions forwarded to us so we can answer them and put them up on our website.
Okay, then I think that would probably be the best way to proceed. So we will definitely collect several questions that we have that are in line here, just to respect everyone's time, and we will make sure that you do get that. And of course, all the participants, as you heard, all those answers will be posted on Q Health's website. And if we were to receive the summary of those question answers, we will also gladly send them out as well if needed.
Oh, that's fantastic, Monique. One thing I do want to say, just because I saw it come across, it's a very important question that I want to answer, is have our survivorship care plans been designed for other diseases than breast cancer? And the answer is absolutely. So we have had our breast and GYN up and running the longest, and that's been we started those in 2014. We have Hodgkin's and non-Hodgkin's lymphoma. We have prostate cancer, lung cancer, and colorectal cancer under development, and those will be live this summer, as well as all the other major tumors. By end of 2015, we will have care plans for 70+% of all cancer types.
Okay, well, that is all very wonderful. I want to take the time now and thank you, Dr. Stricker, and thank you for sharing your expertise and providing us with an overview of On Q Health's technology, reviewing the mandates and standards for survivorship care plans, and taking us through that live demo. We very much appreciate it. And to our participants, we thank you for sticking with us through those technology issues and for taking the time to join us for today's webinar. As you can see now, the slide, we just want to remind you of our CA SNAP resources so that you can visit our websites and you can review the webinar today or see any of our additional reports. You can visit our online academy to enroll into any of our new online trainings, especially the executive training on navigation and survivorship and the upcoming oncology patient navigator training, the fundamentals. We also encourage you to check out our free cancer survivorship e-learning series for primary care providers that provides excellent education on survivorship care, and you can access that again at the Cancer Survivorship Center Education.org. And again, following this webinar, you will all receive an email with the recording as well as today's slides. You will automatically be redirected to an evaluation survey to provide feedback on today's webinar at the conclusion of the presentation. And we're going to go ahead and leave the room open, so if you have any additional questions that you would like us to forward to Dr. Stricker, we will gladly do so. And again, if Dr. Stricker, if you will willingly send us those answers, we can also post them and send them to participants as well.
Fabulous. Thank you so much again for this tremendous opportunity. Deeply grateful and excited to talk to some among the participants today. We look forward to hearing from you. Have a great afternoon.
Have a great afternoon, everyone. Thank you so much.
Bye-bye.
Bye-bye.